Great. Thanks, Pito. So I'm going to, once more, brilliant. Thank you. Okay. So we're going to move ahead. And what we'll do is I've just got a couple of intro slides, which I'll go through very quickly. And then we'll do overall intros. So I hope people are warm. I know it's very chilly, but we've got the heating on. So hopefully that's okay. And I'll do a quick housekeeping. For those of you who don't know me, I'm Jo Veery, Director of the ACMS, African Centre for Migration and Society, and here at WITS. And it's wonderful to see so many familiar, but also new faces here, as well as colleagues online who we will also make sure that we get to meet and include. Bathrooms are just through this door. You can also go outside and back in. And I believe there's also an accessible toilet this side as well. Tea, coffee, we have it replenished at tea time, but help yourself while it's always there. You've got water, so any requests or anything, please chat to Pindile, who's up at the back. I think most of you know Pindile. What we'll also do is hopefully you now have received an email on the Google group, which I discovered I'd not added my WITS email to, which was why my messages weren't coming through. But I've sent a message now with a link to a Google Drive folder. So if a couple of you can just check, that means you'll have copies of all materials that we share, plus any other resources. But importantly, for those of you who prefer to follow along with slides on your own machines, if it's easier to see, then obviously you're welcome to do that. We're recording everything, and we'll generate transcripts from that. So everybody will also have those resources. I know that sometimes some of us, myself included, have a tendency to speak very fast. So please, someone in the room or online, just do a hand waggle if it's too speedy. No one will ever be offended. As we move through the next couple of days, when we have points of clarification, please feel free to raise your hand during an input if it's a clarification that you need to help understand. And then we've always got discussion sessions. So what I suggest we do now is a quick round of introductions before I go through this background so that we know who's in the room. And then I can say a bit more. But I wonder, Soorej, if you wanted to come join me for 2 minutes, and we can just quickly introduce the course. So this is organized under the auspices of the Cluster of Research Excellence in Migration and Health, which is an initiative supported by the African Research Universities Alliance. Many of you know Arua. The ACMS is also an Arua Centre of Excellence. They have the secretariat based in Accra in Ghana. And it's a partnership that then includes the Guild of Research Intensive Universities in Europe. I'll leave Soorej to introduce himself quickly, but we are your North-South partners, although we've worked out that we actually are all the wrong way around because I'm originally from the UK, Soorej is originally from India, Soorej is now in Sweden, and I'm now here. So a truly North-South, South-North collaboration.
Brief, I am Jo from Sweden, in the sense that she's the AU co-lead, I'm the EU co-lead. I am from Uppsala University, up in the north, equivalent of Jo down south. I teach migration and global health, and that's what I've been working for the past 2 decades or more than that. Work quite a lot with UN agencies, and I also had a WHO collaborating center on migration health. We get to discuss a bit more about who I am during the course of the day. Very happy to see all faces, for me, all new faces, except for a few. Happy to be here. Thank you for the invite, Jo.
Great. Thank you. So I thought what we could do is do a quick intro. Colleagues online, we'll start with people in the room to give you guys a chance to sort of catch up with us. And if everyone could just do a really quick intro of your name, if you are currently affiliated somewhere, either studying or working, if you could mention that. I know that some of us aren't, and that's absolutely fine. And just a sentence on what brought you here today. So some of you, it's because I told you had to be here, which I understand. But maybe Langa, we can just start with you. I'm going to do my best to facilitate from over on the laptop as well, where I'm sat. So if I disappear, please don't worry. And I'm gonna just switch the screen over to so we can see everybody online for now. If I stop sharing, does that work? Okay, over to you, Langa. And if everyone, the reason we need to use the mics is so everyone in the room and online can hear, but it also means our recordings capture everything everybody says.
All right. Hi, everyone. Hi, everyone online. My name's Langam Loja. I'm a researcher based at the ACMS, and I have a public health background, and I'm excited to be here working on migration and health issues. Yeah.
Morning, everyone. My name is Gwendolyn Kopozi. I'm a master's student supervised by Prof. Joe. I'm studying with the ACMS.
Hi, everyone. My name is Josie. I work for an organization called HBA, and we are coordinating the GEMS research in the Cambodia site. And I'm here because it's a continuation almost of our annual meeting last week.
So hello everyone, my name is Vichika from Cambodia. We also work at the same organization from Health Poverty Action and also the part of the GEM project. And thank you everyone and nice to meet you all.
Morning, everyone. I'm Tapua Murumbizi. I'm part of the GEMS program, the Messina team, and I'm excited to be here as well. Thank you.
Hi everyone, my name is Bodo Ovumai. I'm a PhD candidate here at Wits University, and I'm at the African Center for Migration and Society. Thank you.
Seriously, good morning. I'm Sir Stanley Tifa from the James team, Messina. Thank you.
Okay, greetings everyone. I'm Wellington Vundura. I am a postdoctoral research fellow at the African Center for Migration and Society. I'm also a researcher in the GEMS project and also an affiliate of Africa University for the same project. Thank you.
Hi everyone, my name is Dr. Ranganesh Dembo, affiliated with UNISA, working on migration and health. I'm very excited to be here. Thank you.
Good morning, everyone. I'm Blessing Mukruva. I'm a PhD candidate at the ACMS in migration and health. Thank you.
Good morning, everyone. I'm Stanley Morava, and I'm a researcher at the ACMS.
Morning, everyone. I'm Tafa Soorej Puthoopparambil. I'm part of the GEMS Zimbabwean team. Thank you.
Morning, everyone. My name is Melissa Dlamini. I'm part of the GEMS PhD scholars and part of a joint doctoral degree between First University ACMS and University of Essex. Lovely to meet everyone and looking forward to the exciting conversations around migration and health. Thank you.
Good morning, everyone. My name is Aditola Oyenubi, PhD student at ACMS. Thank you.
Hi, everyone. My name is Besweet Kudenga. I'm with the University of Western Cape doing my PhD. I'm here to engage with everyone in person.
Hi, everyone. I'm Kudrana Safora, and I'm a pre-PhD intern at the Wits School of Public Health. And the reason is because my paper focuses on migrant health and quality of life. Thank you.
Hi, everyone. I'm Becky Walker, affiliated with the ACMS, and I have worked with the ACMS and with Joe for a very, very long time. And I supervise a number of you here in the room. I work broadly on migration, gender, and health. And yeah, I'm here because it's another opportunity to engage with all of you and to hear all of your inputs and just to be present when I'm normally based in Cape Town and engaging online. So it's nice to be here in person.
Hi, everyone. My name is Kosing Pile, and I'm a master's student here at ACMS.
Hello, everyone. My name is Notando Puti. I'm a master's student at ACMS.
Good morning, colleagues. I'm Zbosiso, a public health student at the University of Pretoria.
Morning, everyone. My name is Pesitle Mahlangu. I'm a master's student in health sociology, and I'm here because my research topic is on undocumented immigrants and their experiences in accessing maternal health care in townships.
Good morning, everyone. My name is Lydia Moyo, a postdoctoral research fellow at ACMS under GEMS. Thank you.
Morning, everyone. My name is Kunda Mzeza. I finished my PhD at University of Pretoria. So I'm here because this winter school aligns with my future goals and I'm still looking for a postdoc. Thank you.
Good morning, everyone. My name is Nompumelelo. I'm in my first year doing my PhD under the Nurture for Youth project and the ACMS, and I'm excited to be here. Thank you.
Good morning, everyone. My name is Shamiso. I am a postdoctoral research fellow with BITS/Africa University.
Morning. My name is Tanatswa. I'm a doctoral researcher with ACMS in migration and Essex in public health. I'm here to engage with everyone. Thank you.
Switch to our colleagues online, and if we could change the view so that we can see online colleagues as they introduce themselves. Thanks. Or I can just share from my side if that's easier. You'll need to stop sharing. Or can you switch it on this one?
That's not for everyone, so you can speak in their game.
Okay, not everyone will have cameras. Pito is trying to speak, but we can't hear him. Huh? Once more, do you wanna try introducing yourself in case we can hear you?
Hi, everyone. Can you hear me?
Yes, we can.
Perfect. My name is once more, and almost done with my PhD at the ACMS. Here because, yeah, I'm hoping to go further in my research around migration and health. So this is a great opportunity to continue networking and to learn more of the work that's been done by Joe and colleagues. Thank you.
Thank you once more. I'm just going through the list as they're showing on the screen here. Over to Nosipo.
Okay, good morning. Can you hear me?
Very loudly, yes.
Perfect. My name is Nozipo. I'm a researcher at the Health Economics and Epidemiology Research Office. I'm interested in looking at aspects of health and migration, so I just joined to understand what it's about. Thank you.
Great, welcome. Pito, over to you. We're not hearing you at the moment.
Can anybody hear me
Oh,
now?
yes, we are now. Yes.
Yes, lovely. Good morning, everyone. Thank you for the opportunity to be here. So my name is Pito Lindo Luvuno, but everyone may refer to me as Pito. I am a master's candidate from the University of KwaZulu-Natal, and I have a background in resettlement. So I think with all the changes that are happening in the NGO space, that's kind of what brings me here to gain a little bit more knowledge when it comes to migration. Yeah. Thank you, everyone.
Thanks so much. We next have Melvin.
Hi everyone. Yeah, my name is Melvin Sinela. I'm first year PhD student at ACMS and part of the Nature for Youth project. Thanks.
Thanks, Melvin. You were a little bit unclear, but just to quickly say, for those that didn't hear, Melvin is part of the Nurture for Youth program and a doctoral candidate as within that as from the ACMS. Next we are to Sizwe.
Good morning, colleagues. My name is Sizwe Ntuli. I'm from the University of Pretoria. I'm doing my master's in public health and this topic is on access to healthcare services. When we met somewhere this year, so I'm quite excited to part of this. So thank you.
Thanks, Sizwe. We had a bit of trouble hearing you. I think your line's a little bit unstable, but you're from UP doing your master's, and I think with Dr. Modisanyane, I think. But it's great to have you join us online. Next, we're over to, let me see, Nireshni.
Good morning, everyone. Am I audible?
Yes, you are.
I'm Dr. Nireshni
Thank you
Naidu.
so much, Prof.
I'm an
Sorry, Sizwe, could you mute yourself, please? Thank you.
Hi, everyone. I'm Dr. Nireshni Naidu. I'm an epidemiologist by training. I have a PhD in public health, specializing in implementation science. Prior to the US government funding cuts, I was affiliated with RHI as a senior researcher. And I'm here today because I would like to expand my knowledge and skill set around migration and health. Thank you for having me.
Thanks, Nireshni, and solidarity with you, colleagues, and many others who've been impacted by the USAID cuts, and we're delighted to have you join us today. And last but by no means least, we're over to Chavi.
Hello, everyone. I hope you can hear me.
Yes, we can.
So I'm so excited to join with you. I am Chavi Chaudhary, and I am a doctoral researcher at Department of African Studies, University of Delhi. I'm working upon migration dynamics and political agency and identity dynamics of migrants in India and South Africa. So I am a newly enrolled doctoral candidate in the university, and I hope to get a lot of insights from this winter school. Thank you for having me.
Wonderful, wonderful to have you, and very, very welcome. What I would like to do is, I think, Anuj, sorry to pick on you, we missed one person who has joined us. Anuj, do you want to just give a quick intro? And if you could use one of the speakers so we record you, that'd be great. Thank you.
Hello, everyone. Nice to see so many faces again and also new faces. I'm Anuj Kapilashrami, and I am a professor in global health policy and equity, also direct the Center for Global Health and Intersectional Equity Research. It's a mouthful at the University of Essex. And I am delighted to be at the Winter School. It's something which we are supporting as GEMS Global Health Research Group, which you probably already introduced. So yeah, okay, thanks.
We're going to share a bit more about GEMS when we come to Anuj's input a bit later. But I think it's an acronym that many now in the room will have heard from lots of people. So we're keeping it as a surprise. Did anybody else join us and miss the opportunity to introduce themselves? I think everybody is here who was there. Yeah. Okay. So what I wanted to do very quickly was just share a couple of slides. Do I need to share from this machine, or do I share from your side? I can't share here. Just to go on to those. Okay, I think I've got it. Okay. And I put it onto presentation. No? Just very briefly about the core. You've now met Soorej. I'm not sure if the map is showing up here very clearly, but as I mentioned, all of the slides are in the Dropbox, in the Google Drive link I've put together. So I just wanted to flag that, as Soorej said, he's up here in Uppsala, we're down here in South Africa, and it's a network that is exploring the relationship between migration and health and how to address the need to ensure that migrants along this very important migratory pathway have the opportunity to access good health status, but also to look at how that then impacts issues around migration, development, and the entire migration journey. You'll see that we have various partners who are along this network pathway. And one of the important ambitions of the core is working with earlier career researchers and doctoral candidates to bring everyone together. So this for us is a really important opportunity and something, along with people like Anuj, Becky, and others, Langa and others in the room, who see this as a core part of our work. Many of us work in research centers where our responsibilities are stretched across too many things, but I think it's important to recognize that those of us who have the opportunity to be involved in supervision and working with students, that's what we'd rather spend our time doing than many of the things we get pulled into. So really building capacity in migration and health in that broad field. And one of the ambitions of the next few days is really to interrogate what we mean by the field of migration and health. And we're going to have a chance to do that in this afternoon, really go into some debates, because many people see migration and health as solely this kind of very public health or this epidemiology focused space. In the room, I know that we have people with very diverse backgrounds and online, and we need to work out how we can ensure that colleagues working across different disciplines can work collaboratively within inter and multidisciplinary spaces. So keep that in mind as something when we move on to Soorej's input and the rest of the inputs this morning, is to really think about where you fit in, but also where others you have the opportunity to work with fit in. Importantly, we don't see this being limited to people who are part of an academic program or are working within a university system. This applies to colleagues who are practitioners, colleagues working in community organizations, colleagues working in international organizations, regional economic communities. And part of our role is to say, how do we bring all of these actors together? So research is critical, but research is not simply about thinking about those of us who are doing or have done postgrad education. It's not only about those of us who are based or want to be based within university structures. And that's one of our responsibilities collectively to think through that. We use the idea of a whole of route approach. Now, this is important because we know, and we're going to be talking about this over the coming days, one of the limitations of migration research generally is the fact that we too often focus on one point in time and at one place, which is sort of contrary to all of our understandings around movement and mobility. So how do we better engage to think about an entire route, thinking about people moving within, back and forward, when there are times where we're static? I think most people in the room here weren't necessarily born in Johannesburg, but here we are all today. We move at different times for different reasons, for short term, for longer term. Some people are forced to move, some of us choose to move. So understanding those vulnerabilities and privileges along this continuum is absolutely key. We also think about a whole of society approach, and some of you, particularly those of you in sort of public health spaces and health governance spaces, will be familiar with this. It's sort of a way of trying to say very quickly, everybody needs to be involved. Taking this very kind of as though we can quickly and easily put everyone together. But it is our job to try and figure out how we can do that efficiently and effectively and not leave certain groups behind who are clearly involved in issues around governance. When we're talking about migration and we're talking about health, we're not simply talking about one small group of governance actors. We're actually saying something quite complicated. Health is political. We know that the movement of people is political too, right? So our job is to find a way to sort of merge together these two politically unpopular areas of interest and importance and find ways to encourage those political leaders, those people who hold that kind of power to really affect change. So we've got no easy tasks. And then finally, one of the things that Soorej and I, but it also is mirrored in work with people like Anuj, people like Langa, is the development of joint postgrad training programs and thinking about how we can expand that into spaces outside of the academy, as it were. So we're starting to implement that. We've met colleagues from University of Wits who have University of Essex. It's a joint degree program. So an opportunity for younger folk to spend time in two very different contexts. We've got, for example, some of the students from Soorej's master's program are coming to undertake internships here. We've had early career researcher from Ghana spend time in Uppsala. We're in the process of appointing new postdocs who also will be across those two spaces. And part of this really is thinking through how can we expose people who are training, but also those of us as we continue within our careers and continue trying to learn as we move through, how do we engage across these different contexts where there's a common political challenge, but different ways of addressing issues around migration and health. So I'm going to stop there. This is the background to why we're here. It's an inclusive space, and I'm delighted to welcome you all here into WITS. Some of you know WITS probably better than you wish you did. And for some of you, I think it's a newer experience. So Soorej, if I can hand over to you for the first input. I'm aware we're running late, but we have a nice flexible program. So if you don't mind, we're going to push tea a little bit later and see how we kind of catch up with the program. Let me just try and open your slides for you. You've got a PC, right? Yeah, you'll be able to find them. I think they were dragged onto the desktop.
Now, good. I think for this presentation, I'll use my Indian background in keeping the time. So probably around 25 minutes. Let's see. So Joe already mentioned core, and I already mentioned who I am, so I'm not going to spend time on it. But I very much like what Joe was introducing before about what is actually migration and what's actually health or public health on that matter. And I'll try to discuss a bit more. What I'll try to do is that sort of explain the concepts a bit more because you all have from different backgrounds, as we heard during the introduction, and then also try to provide sort of an overview of the current state of evidence, what is there or not there actually. So this, I think it's an obvious question, and usually I do this in an interactive way, but I try to keep it not this time because we have a discussion later on. Somehow, even if you just give an example, if you just Google the word health on your mobile phones or laptops, what you often see is doctors and nurses or people in white cloaks or hospitals. And for me, somebody who has been working global health, that's exactly the opposite of health. See, WHO defines health as a complete state of well-being, not just physical, mental, social well-being, but a lot of other factors as well. For me, working global health is even important because it looks into equity in health. That is the difference in health between various groups, be it migrants versus host population, be it male versus female, and so on and so on. And this has to go across the board, not just within a country. If you see health from a larger perspective, any public health or global health system, the aim is to keep people healthy and to promote health. And think, what do you guys need to be healthy? Probably a good house, good education, a good job, and a good work insurance. None of this is actually about health sector. It's actually everything outside the health sector. And that's actually where health is created. And I think that's a common issue when we work with global health or migration health. We always tend to focus on hospitals and the buildings and so on and so on and so on. But actually the effort has to be done somewhere outside the system. And that's where the intersectoral and the multidisciplinary approach comes into play. So for me, health is everything that where it is being created, which is often at the house, a workplace, or the schools and other places. It's when those systems don't work, you go and seek health care. So remember the difference between healthcare services and health services. Health service is not actually giving vaccine. Health service actually giving the school meals could also be as a health service, could be depending on how you define health. Now, this, I guess most of you are familiar with what it is. This is one of the, I wouldn't call it as a definition because this is not necessarily officially endorsed, but this is one of the widely used descriptions of migration. This is the latest one by IAM. So if you looked at the year before, say from 2018, they had a bit more elaborate with a lot more subclauses because, as you guys know, there is less agreement on what migration and migrants are. They went for a more broader description. So pretty much anybody moving within or outside a state, regardless of the time, regardless of the reason, and so on and so on. So just this is where my migration health comes into play. I'm just going to keep an eye on the time part. So the size-wise, I guess this is all something quite familiar to you guys. So if you add both internal migrants, so the ones who are moving within a country, regardless of the reason, be it forced or not forced, and if you take the international migrants, the ones who are moving across the national border, there are more than 1 billion migrants globally. And this is an underestimate because, for example, the number I quote in then, 763 internal migrants, that's from 2013. And nobody since then bothered to do another estimate. And as you know, internal migration is the largest countries with like South Africa, Russia, India, Brazil, and so on, China, and so on and so on. So more than 1 billion, I would say it's underestimated. It's probably more than 1.5 billion or more than that. And among international migrants, the ones who are moving across the board, more than 60% are labor migrants, the ones who are moving for the reasons to work and money, and depending on the context, send it back home, remittances, so to say. This, I would like to emphasize a bit more because there's a lot of discussion and often it's politically charged. I don't know how often you guys how long you have been working on migration health. So if you take prior to 2016, 2015, we often spoke about migrants as general, the number and so on. Since 2015, since 2016, we started to talk about refugees and migrants. And I don't know how far you have discussed this topic. For me, as a researcher, shouldn't be the case. It's sort of saying as roses and flowers, because both are flowers. But due to various reasons, hopefully we can get into that later on, there is a political movement to say, no, these are refugees and migrants. And that's why I want to show this figure. So this is the latest figures actually come from UNHCR on 12th or 20th of June. So this is the, the thing in the parenthesis, highest ever recorded number that I've been putting on since 2015 because it's just been going up and up and up. So this is the number of forced migrants who are forced to leave from the place of their habitual residence, either within a country, then they become IDPs, internally displaced persons, sorry for the abbreviation, or across a country. So you become either refugee, asylum seeker, and this is a new term UNHCR coined 2 years ago. So for example, people in need of international protection. So these are, for example, Venezuelans in Colombia. They have not necessarily sought protection because they are afraid they might get rejection, but UNHCR considers them as individuals who need protection but have not applied. So these are people in need of protection but have no protection status yet. So if you take the first three figures, 31, 8.4, and 5.9, these are the international, I'm using the word migrants, among the forced migrants, the ones who have been forced to move across the country. And that's only 15% of the total international migrants. And I'll come back to why I'm showing that number. So just keep that in mind. Among the totally forcibly displaced population, only 15% are across their own country of residence or country of habitual residence. So at least now we know what is sort of the definition of health, migration, and the size, the normal migration, and then the forced migration part. So ideally, the evidence, the research we do should be reflective of that population, right? One more thing I also forgot to mention that most of the migration actually happens within the region. So within Africa, most of the migration actually within the region. Be it force, be it for labor reasons, it's within the region. Same in Europe, same in Southeast Asia, and so on and so on. And when it comes to forced migrants, I think now it's like 73 or 74% are hosted within low and middle income countries. Not in US, not in Europe, not in Australia, and so on. And now probably this makes more sense. This is a map done in 2016 by colleagues from various places, but also led by IAM. This is a bibliometric analysis. What this does is that it looks into where evidence on migration is being produced. So the purple, blue, the red, and so on, these are the countries with the highest proportion of literacy is produced. So remember what I said before, most of the migrants migrate within the region. When it comes to forced migrants, they are in low and middle income countries. None of the colored countries are actually LMICs, low and middle income countries. And then it also means that who produces the evidence, who gets the voice, and who it is being said. Linked to what Joe was saying before, quite a lot of might be actually on refugees who actually arrive in these countries or labor migrants in these countries, whereas you still have a lot of labor migrants in South Africa and other parts of Africa and so on. But this is the evidence what we are working on. So also keep in mind when we talk about evidence-informed policies, this is the evidence that is informing the policy. And then you can imagine how skewed the policies might be. Another way of looking at it, this is a pie chart from a recent WHO report we produced in 2022. This was the first ever WHO global report. We led it from Uppsala. So what we did we did a large literature review, and we looked into which populations were covered in this literature, this globally. So as you can see that refugees actually cover 31% of the global literature on migration and health. And these only international migrants. Remember, as I said before, around 11% or so, only among the forced migrants, only 11% are international migrants as refugees. 11% of the population group, 31% of the literature. And then I said more than 60% labor migrants, international migrants are labor migrants, and that's covered around 17%. Who gets to speak, who gets chosen to be researched upon, and what is the evidence we get? And then Are we using the research from refugees who are forced migrants for various reasons to generalize and make policies on labor migrants, or vice versa? How do we work? How are textbooks formed? How are policies formed? Just keep in mind the layout of the literature. And this is a quote from the WHO report. More than half of the literature actually focus on health status, and more often on how sick or not sick you are. And imagine, as I said before, where is health created? Is it at the hospital? Probably not. But the literature is still talking about the health status of are you malnourished? Are you stunted? Do you have HIV? Do you have TB? And so on. Not necessarily understanding why and how it is being caused, rather than the outcome. What is your health status? And that's what the literature is showing about. And then in that, around a quarter actually looking just on communicable diseases. And this is something we see across the globe. The reason being simple, because I cannot infect you with my PTSD or with my depression, but I can infect you with my TB. Also, then imagine, where is the funding going? Who decides what gets to be funded? I'm sure you have heard from Trump and a lot of others, these people are coming with diseases. So then let's do for communicable diseases. And actually, in many countries and few countries in Europe, actually, people are being detained for TB screening. They get screened for TB and ensure that you're not there. Then only you are even allowed to apply for asylum, for example, in Malta. So a lot of research being done on communicable diseases and few on mental health, even much less on NCDs, non-communicable diseases. As you know, the health systems and health status across the globe is improving. And actually, we in global health and public health, we call as the disease transition. People are moving away from having a higher burden of communicable diseases to a higher burden of NCDs because living standards increase. But that is not necessarily being focused. For example, in Europe, traditionally, we always looked into communicable diseases, HIV, TB, and so on and so on. But for example, within the Syrian crisis, we see that there's actually much more prevalence of non-communicable diseases because Syria was a well-functioning country until the war broke out. They had a much advanced health system. They actually have more issues of high blood pressure, NCDs, and so on, which is not reflected in the literature. So now we know the concepts and the lay of the land in terms of where and how research is being produced. Now, just to give some stats and numbers on health status, this is a box plot. This is bit old from 2018. The categories you see on your, which side is now? Left-hand side, this is known as ICD-10, International Classification of Diseases. So basically how we classify diseases in different ways. And what this does is that it compares the health status of international migrants versus the health of the host population. Any dots you see on your left-hand side means that migrants have a mortality advantage, or in simple sense, they have a less risk of dying. Any dots you see on your right-hand side, it shows that migrants have a higher risk for dying for those particular disease categories. So left-hand side, less risk of dying for migrants, higher risk for dying. So if you look the graph a bit more closely, you can see that for most of the disease categories, you actually have a mortality advantage for migrants, international migrants in this case. What this says is that migrants are healthy, or healthier, not healthy, healthier, I would say, which to me is not a surprise. So I don't know how many of you guys have tried to maybe apply for a visa or a permit to Canada, or UK, or Australia. I'm sure you always had to answer questions on health. In some cases, you even have to do a health checkup and submit it. So this is not rocket science. They pick the healthy ones, so then they're healthier. But again, understand the difference between what is being discussed in terms of data. I said these are international migrants. What I didn't say was that most of the international migrants in this was labor migrants, not refugees or asylum seekers. So if you add them to this box plot, I would say it will look more or less the same, but the dots will be a bit more closer to the dotted line, because they would probably have a bit more health challenges because of the reasons why they had to migrate. But still, traditionally, they'll be more healthier because it's the young and the healthy who can move. Migration is an easy thing. It costs in terms of money, but also health-wise. So the ones who are weaker, elderly, or other kind of people with vulnerabilities, they often don't migrate. Still, it's the healthier one who gets to move, who can afford to move. So this is sort of also known as a healthy migrant effect, which in the due course changed to unhealthy migrant effect due to living conditions, which I get back to later. So just want you to keep in mind, migrants tend to be healthier when they move, at least when they move. This is a map of the WHO European region. I did not have an equivalent of that for the global region. This is something we produced in 2018 when I was at WHO. The trends and patterns are not different. There are various colors. So if you look at the, I don't know what do you see, like peach, pink, whatever color that is, it shows that around 58 to 85 or 90% of all newly diagnosed cases of HIV are amongst peoples of migrant origin in the WHO European region. The ones with yellow, that's Central Europe, and they have less proportion, maybe around 10 to 20 and so on. You see the numbers over here. And this is confirmed by the number from ECDC, European Center for Disease and Control. It says, I guess, EU is not same as Europe and bigger one, right? EU is a smaller, it's only 27 member states. Europe is much bigger with Russia and other parts of the world. So within EU, around 50% of the newly diagnosed cases are among migrants, which, well, in a sense makes sense of what, some political leaders say, they bring disease, they bring HIV. But what this figure doesn't say is something known as the post-migration acquisition of HIV, meaning you got HIV after you migrated. This is not a big data set as I showed in the bigger one, but it gives an indication. So what this chart on your left-hand side shows is that migrants from Europe, within Europe, migrants from SSA, Sub-Saharan Africa to Europe, migrants from Latin American, Caribbean to Europe, and so on, that many percentage of them, they got HIV after coming to Europe. In Latin American, Caribbean, and SSA, HIV is a challenge. It's highly prevalent. And these are the healthy individuals who managed not to have HIV, come to Europe, then get HIV from there. And we could actually look back because we had the data on when they came back, when they arrived in Europe. We could actually do a simulation based on CD4 cell count and so on. So they actually got infected after coming. It's not that they got tested after coming to Europe, but they actually got infected. And this is this you wouldn't necessarily see. I'm trying to go back. Yeah. You wouldn't necessarily see over here. Just says, 50% of migrants actually have HIV, but not necessarily where they got it. And this is where a lot of the policies we need to discuss come in. Why do they get that? Is it because they have less access to healthcare? Are they in an exploited context? Because, if you are an irregular status, undocumented status, men and women can be exploited. Are they abused along their route? Or is it because simple language barrier where they know what their rights are, where they can seek healthcare, where they can ask where can I get condom and other kind of things? So this is a missed opportunity in the host country's health system. I'm not sure what the slides are actually doing. Okay, yeah. So this is communicable disease, that was HIV. This is TB, shows along the same picture. The dark blue colors are the countries where migrants have a higher proportion among TB cases, and the other shades are a bit lesser. This again is sort of simple mathematics. If you go to a country where there is low prevalence of a TB, let's say it's a country with 5 people having TB, and there comes 100 migrants, of them two have TB. So of the 5, 2 are migrants, all on 50%. If you go to a country where there are 10 individuals with TB and the same group of migrants goes there, then it's 2 out of 10, that's 20%. So what this says is more about the host country's health system. That's why, for example, Russia up there is light in green, because Russia and parts of Central Europe, this is part of the world where TB is actually on rise, similar to South Africa. So South Africa is a country where TB is a challenge. But if you look at the difference between migrants who work in the mining industry and the rest of South Africa, you can see 3 to 4 to 5 times higher prevalence of TB among migrant workers in the mining industry, who are migrants basically. Within public health and epidemiology, we also call TB as a disease of poor man's disease. It's the living conditions that make them more susceptible and more risk of getting TB. This sort of pattern you can observe for many of the communicable diseases. Non-communicable diseases, meaning the disease you cannot necessarily transmit. If I'm going to put all those in a nutshell, on arrival, they seem to be healthy. The longer you stay, you become less healthy. You get sort of diabetes, high blood pressure, and those kind of diseases. NCDs, that's the pattern we see. But there are also some genetic makeup that makes things a bit different. For example, individuals from Southeast Asia tend to have a higher risk of having diabetes compared to Europeans and other parts of the world. For example, females from north part of Africa tend to have higher risk of overweight. And these are studies what we have shown. So there is gender difference, there is regional difference, and so on. But the bigger thing what we need to look into is also the occupational injuries, because injury is a non-communicable disease. And there have been recent systematic studies showing that being an international migrant, international labor migrant, increases the risk of having occupational injury by 50%. So being international migrant, every day morning you get up and get out, that's a 50% chance I may or may not get injured compared to a non-international migrant. It's because they work in so-called 3D jobs, not the three-dimensional, but dirty, demeaning, and dangerous. Construction, driving, mining, housemaid, and so on. It's that makes them higher risk of occupational injury, not any other genetical makeup, so to say. Mental health. I have a colleague, he's still at IOM. He used to say that many times the mental health challenges the migrants face, these are normal reactions to abnormal situations. So the challenges they face, the depression, anxiety, and so on, it's not abnormal because that's the challenges they face through. And as we all know, it's the living conditions. That's what makes us a toll on the mental health. But for refugees, asylum seekers, and others who might have experienced violence and torture, those kind of events, they have a higher risk of developing depression, PTSD, and all those kind of things because of the experience they went through. Other than that, migrants generally don't necessarily have a higher bad mental health, considering the situation they are in. But of course, if you compare a migrant with a host population who have insurance and everything, of course, they'll have a higher risk of mental health issues, be it depression, be it anxiety. But it's the living conditions that matter. I'm going to soon finish with 2 or 3 more slides. I want you guys to keep in mind 2 things. The difference between migrant health and migration health. Sounds just play of words, but it's much bigger than that. Migrant health, it's actually the health of the migrant, the individual who have migrated. Whereas migration health is how the process of migration impacts the health of migrants, the people they interact, say the host society, and also the people they are left behind. Say a lot of labor migrants who migrate and send money back home, or friends and families there. So what we often deal with something known as migration health, not necessarily migrant health. Because if you're looking at migrant health, you're not understanding the context. Let's say a labor migrant who comes to work, say in Malaysia or in Dubai for that matter, and you do everything for migrant health, but the reason why he's cutting short on his food or have a poor living condition is because he want to save money and send back home is to family and kids. Without understanding that context, doesn't matter how much you're going to do for that individual. So the focus has to be on migration health rather than migrant health. I'll show a few examples. So how does migrant health impact host population? So this is a chart showing the proportion of migrants in so-called essential workforce. This is from Europe. Essential workforce means teachers, nurses, firefighters, and those kind of things. So as you can see, in countries like Ireland or Sweden, around 1/4 of the essential workforce are migrants. So them being there, it keeps them healthy, but also it keeps the host population healthy. Imagine like in the UK or in Ireland, where it's like anybody with a migrant origin in the NHS or health service, no, we are not going to work, or everybody's going to be deported. 1/4 of the workforce is gone. So this is one example how they impact the host population's health. This shows how they impact health of the people left behind or in the home country. Remittance is the process of sending money, basically international labor migrants sending money back home. So this is a chart from the World Bank. What it shows is that the red line, that remittance has been increasing from 2000 under 2025, is around 656 billion US dollars. You compare that to FDI. FDI is the orange dotted line. That's foreign direct investment. So like say, I don't know, UK comes to South Africa and invest money in XYZ, or I'm sure you're familiar with China coming and investing something. That's foreign direct investment in that sense. ODA, Overseas Development Assistance, aid money, that's the aid money given to various countries. So if you look at if you take any country, this is a general estimation, the remittance is 40% higher than the direct money given by the foreign government. 60 times higher than the aid given. So imagine if anybody actually wants to help another country, it's enough to allow people to come legally and work and send money. If I, as a father, want to send back $10 to my wife and kids back in country X, probably the wife is going to get $9 of my $10 because I need to pay fees and everything. If I'm going to give that $10 via aid, imagine the bureaucracy that goes through, and the mother and the child might get $1 or 50 cents. It's actually more effective. They come here, they actually contribute to the economy. I showed you the graph before. They work in essential workforce and so on and so on. So this is actually the way to work on, and this actually helps the home country, because many countries, around 41 to 30% of the GDP is just based on remittance. In Nepal, for example, I think it's around 24, 35% of GDP is actually just remittance. And it's the GDP is the total amount of money the country has to build roads, schools, hospitals, and so on. So this is how migration also impact the health of the people back home. So it's migration health, not migrant health. I'm just going to finish here, just showing what is determinant of health. Determinants of health is basically the conditions you live, age, and work. And when we did the WHO report, we created a diagram like this. What shows is that you have the various phases. The green one, you start there before you migrate. The transit phase, depending on what kind of migrant you are and your route, your arrival, and maybe the return. In all these phases, you need to look at the age, the sex of the individual migrant, how that impact health. In some contexts, female migrants are much preferred as nurses, housemaid. In some contexts, male migrants are preferred as drivers, as construction workers. Then in other contexts, being a female migrant, you're much at risk being exploited. There are a lot of stories being people from Southeast Asia, women being abused in Saudi, in Israel, and so on and so on. In other places, it's the other way around. Individual lifestyle factors, society, community networks, living, working conditions. Do migrant workers get insurance? Is it a language they can understand? Do they have the same level of protection? Recently, there was this big battery company in Sweden called Northvolt. It's supposed to resolve all battery cars across the world. It went bankrupt within 1 year of establishment. The people who are impacted most were migrant workers. They came to work in Northvolt. Once they lost the job, they had 3 months to find a new job or leave the country. So how are systems being created on that part? So that's what I said. Health is actually created outside the healthcare system. And this is sort of, at least to me, driving the point home. I finish here. I'm sure I went beyond my 20, 25 minutes, but I stop here. Thank you.
I think what we should do is, in shifting the program a little bit, is I think let's take questions, comments, thoughts, points of clarification for Soorej, then we'll have a break and come back afterwards. So over to the floor. I've got the Zoom open here for anyone online. Are we able to show just the Zoom screen with the people who are online? Do we stop sharing from this one?
I think it's already stopped.
Okay. Great. Yeah, on my screen, I can see like everybody.
I think
that's fine. Okay, would anybody like to kick us off with any thoughts, reflections, questions? And online colleagues, please feel free to pop questions in the chat box if that's easier.
Good afternoon, colleagues. It's Sizwen Tuli here. Mine is just a comment, really. I don't know if you can hear me.
Yes, we can hear you loud and clear.
Yes, thank you so much for the very informative presentation. And when I saw the sort of the stats as to where the migration research is produced, it sort of like confirmed what I've always suspected in terms of how the migration policies are being politicized. And today, when you showed that research, the research, most of the research is coming from the north, but most migrants and immigrants and asylum seekers are coming from the global south. And I think that was just a mind opening for me. Thank you.
Thank you. Just to clarify, asylum seeker and refugees, they come, but also they stay also many parts in global south. So yeah.
Thank you so much for that.
Tanatswa.
Thank you very much for that well-rounded presentation. I have a sense, which I wanted your input on, that the real framing of migration policy, migration discourse, especially at a political level, is around not shifting power across states and nations. Because if it makes sense that the way to, if you look at the global compact, let migration be orderly, let it be safe, let it be regulated. Also looking at the evidence from the remittances, allowing people to move in a regulated and orderly and safe manner helps both the host countries as well as largely the communities where they've come from. But that argument and evidence, for me, is not taken on board by the global power drivers, because it shifts power and helps communities really develop, because the money actually gets to the communities in that way. And also, the reason, if you look at forced migration, is there's a lot of even when you look at climate-induced displacement, most of the forced displacement based on conflict around the world, there's also that instigation and input and interference by the same powers that refuse these people to move whom they have disturbed. So does that assessment capture the real organization around why migration discourse and policy is structured the way it is? That because if this evidence is used appropriately and correctly, it shifts power and responsibility in ways that disturbs those that hold the power that has to be shifted in that way.
It's a good question and a complicated question, just to give the answer to. I don't know how much of the power play will be in there, but of course there is a lot of self-interest to be observed there, but I don't know if it's power or not. These days, actually, countries, regardless of where you are from, they would like to use their benefit. If I have a need for healthcare workers, then I'm going to promote that. If I don't need to promote that part. So I can pick and choose. But also the key part is that now, for example, the Swedish government, like in many parts of Europe, the narrative is changing. So previously, within the aid budget, they had around, I don't know, 100 million, 150 million Swedish kronor for 3 years to work on migration. Last year onwards, they have 1 billion Swedish kronor to spend in 3 years' time on migration. But two, this is how it is written, address the root cause of migration in major countries of origin. So basically try to stop migration. So they're okay to invest the money in that. I think in terms comes to migration, it's less of money, it's more of the narrative part. I don't think any of the Europeans or anybody for them will actually care. I mean, mind actually people who are educated people coming there to work in old age homes and drivers and all those kind of things. But it's the sort of the mistrust and the narrative within the context that actually makes a difference. I can give an example. I have worked and I still work a lot with immigration detention, where people are being locked up before being deported. And that's a very costly endeavor. In Swedish context, it would take, say, around 600 euros per day per person to detain a person. And now we are reaching around 1,000 places altogether, right? And I can show through my evidence that a lot of places where actually I saw that we can actually achieve the aim of deporting a person without detaining. But that doesn't fly there because the aim is not saving money. The aim is actually politics and a symbol sort of showing that, this is how we treat people who are not belonging to us. So their money is not a part. In other contexts, money makes sense. I know, for example, Norway has an agreement with one particular state in Kerala. Finland had an agreement with Ethiopia where they actually pay the tuition fees for nursing students in a particular school for all of them. The agreement is that half of them, I don't know exact number, would actually then end up working in Finland or in Norway for that part. So this is also how they try to address the brain drain. I don't know how much of addressing is that. But one point you mentioned is also interesting. I think we as researchers, we as practitioners, we also need to take the responsibility. See, data is not evidence and evidence is not information. A glass is half empty, is half full. Both are honest facts in that, right? But what is it you want to hear? See, if I'm going to work on, say, human rights, and if I want to work with the government, while it is true that the glass is half empty, maybe that's not where I'm going to start. I will say that the glass is half full. See, you already done this kind of thing. You already signed. It's good. So how can you make it better? Or if you want to work with UN agents or others, you might see. So we also need to know that it's not enough to produce good evidence or good data. You need to know how to present. And that's one thing we as the core try to do it, like training and workshops and so on, how to help you guys to work with it. And this is something I do with WHO and a lot of governments on a regular basis. I can give another example. When immigrants are being put in detention, they do not go any health screening in Sweden. And I asked the question, why are we not doing it? It costs money. Of course, it costs money. But imagine if some of them actually have TB, and then you're putting your employees at higher risk. The labor law in Sweden is quite high. That rang a bell. It's the same thing. I'm not saying anything different, but it's about we need to know who our audience and how we present. For some, it's the systematic review, the meta-analysis, the big article that makes sense. For some, it's the top 10 tips for policymakers. For some, it's a training workshop. So yes, power is involved. There is self-interest. I think we all as human beings, we have, and I'm sure you see that quite a lot in South Africa with migrants from other parts of Africa. And one more thing to remember, most often when we talk about migration, we are actually talking about immigration because that's where the evidence is. We don't talk much about immigration as with an E, people moving out. If the global South does more research, I'm sure that'll be more of the research will be on immigration because that's where people move out. Again, another bias in the evidence. I don't know if I answered the question, but around that. Yes, please. Kundai, if that's right. Correct.
Kundai.
Yeah.
Okay, so mine is just a comment on what you've presented. Your presentation, Doc, it was just eye-opening. I just want to comment on what you said about like when you migrate, your healthy deteriorates.
Your health.
Your healthy, it deteriorates. Like when you're migrating, you're looking for greener pastures, you're looking for employment, you want to improve your healthy, you want to improve yourself. But like when you say about like when you migrate, actually your health can actually deteriorate. Like your health is compromised and stuff like that because of different issues. It links to my PhD. I did about female migrants in precarious occupations. Like there's a lot of pressure and stuff like that. The work is unpredictable. It contributes to their mental health and stuff like that. So their health is like, it deteriorates rather than like you improve your health, you improve your well-being and stuff like that. Yeah, it was just eye-opening.
Right. Just to add, it doesn't have to deteriorate. Again, it's the living conditions that matter, right? So, I mean, if you migrate and then if you're in a well-to-do situation, you do exercise regularly, you get good food, and then it's fine. But I'm sure, I don't know how exactly how it's in South Africa, but usually it's cheaper to buy junk food than good and healthy food. So if it's a migrant who want to save money to send home, of course, he might eat more of junk food because he want to send money back home. But also the conditions you mentioned, the precarious situation. So, like if you're a legal migrant, then many countries you have health insurance, meaning even if you're sick, you get still the payment, you can still pay money, or it's okay to seek healthcare. In other places, if you're sick, you don't get the payment. Then you don't get to seek healthcare. It's those conditions that make you more unhealthy. So it doesn't have to be that you will be, but the conditions that can make you more less healthier. I can't see your name, sorry.
Okay, thank you very much for the insightful presentation and your presentation of statistical evidence relating migrant health or migration and health. So mine is just a reflection and maybe somehow related to what Tanatswa and the earlier respondent have said. We ask you as senior researchers of migration and health and other budding researchers, I think there's also need to take a critical perspective where we think beyond the statistics. Because first, the statistics can be part of a global agenda in terms of biopolitics, power dynamics, controlling nations, who has the power, where should certain bodies be in terms of migration, and what is their health at a particular time that could be used to push certain agendas. Secondly, given the evidence, it might be credible evidence like the one you presented, but who has control, the ultimate control over that evidence behind the laptop? Who makes the final decisions relating to that critical data collected within communities in certain fields?
Yeah.
So there could be a certain war, which is mainly epistemological.
Right.
Where is the biography of knowledge? Who is producing that knowledge on migration and health?
Right.
And why is that knowledge being produced? So it's just food for thought. For instance, we have the idea of Fortress Europe, where it is easier for those from the global north to migrate to the south. And the nomenclature used, for instance, could say these are expatriates. But when you migrate to the Fortress Europe, where it is increasingly difficult for those from the global south to migrate, you could be called something else, maybe migrant workers. So that dynamic, it's also very important for us from a critical perspective to think through as we go through this workshop. Thank you.
I fully agree. Data is something I work quite heavily with a lot of countries, and I do actually training actually on how to collect, what to collect data. And this is not the research data, but rather routine data. Yes, you're right. There is also this still the notion of global not deciding, but when it comes to the stats, I'm not sure if that is always the case. So I've been in several meetings where actually, I don't like to use the term global north and south, but for the purpose of discussion, let me use that those terms. There are actually countries from the global south saying, no, we don't want to use it. And there are also actually countries from the global south you are actually championing. For example, I didn't get into like, who is actually a migrant? How we define them, right? Is it your country of birth? What if I moved to country X when I was 1 year old? Is it still my country of birth that is relevant? Or is it my country of birth of my parents? Then you come to, oh, then you are second generation migrant. But no, because I did not migrate. How am I a second generation migrant? If you want to extrapolate it, like my kids, they look like me. I mean, because they are Indian, because I'm married to an Indian woman. And they are small. They're like 6 and 4. I'm sure they're going to be 13 and say, where do you come from? I'm from Uppsala. No, but where do you really come from? That's a simple question, right? But that could actually long-going consequence for the child, because for her, Sweden is a country. But why am I being asked that question? It can lead to an identity crisis. But then is that person a migrant or not? Or for epidemiological purpose, like the one I showed on HIV, the researchers could make their assessment because they had the date on date of arrival. I could count back. And then this is not just a matter of so-called rich countries and doing something. It's also a lot of politics in that. When we published the first WHO region report, I wrote one line there saying that in the European region, we have internally displaced persons. I'm not going to say the country name because we are recording it, in countries X and Y, but this report will not discuss those populations. We will only discuss international migrants. That's only one line I wrote. We published the day after this country called back and said, no, we don't have any internally displaced persons. Of course you do. There is data from the UN agency showing that. No, we don't. And a lot of these UN agencies, we think they are technical agencies. Yes, but they are more of a political agencies as well. We are forced to take the report back, remove that one line, upload it back. And these are not necessarily countries from the global north, so to say. And there, another example, when we develop policies on migration health, for example, when we write the terms sexual and reproductive health, certain countries from the so-called global south, no, we don't want that in there. So while there is still the former colonial sort of power structure still influencing us, it's not all that. Like you see what's happening in South Africa with migrants from Malawi, Mozambique, and so on and so on. It's nothing to do with global south. It's basically a difference in power. And that exists at global level, region level, national level, municipality level, in the village level. So I think power, yes, but not necessarily always who decides and what decides. Nowadays, global power is interested in investing in global south so that people don't migrate. The reason is different. They're happy to invest. But the migration trajectory is not as simple as that it is.
There were a couple of comments online that weren't showing here, but I just want to share them because we're going to be coming back to them throughout the next few days. So huge thanks, Soorej, and I think some really important questions from the room, which we're going to continue returning to, particularly around issues of like knowledge production, knowledge politics, those sorts of things. Xavi shared a few days back, there was syringe attack panic in France, which disproportionately fueled suspicion towards migrant communities. We often see governments responding with heightened surveillance, border testing, and biometric health data collection. How can states ensure that their response to such incidents prioritize public safety without reinforcing xenophobia or compromising the dignity, privacy, and rights of migrants? What role should media and public health institutions play in managing narratives to prevent moral panic? You know, I think this is something, again, we're going to keep returning to, and particularly the session on Thursday, where we're going to be focusing specifically on issues around communicating and narratives and stigma. We have colleagues from IOM, the International Organization for Migration, running a session in the morning that really is going to help us sort of try and unpack some of these issues, particularly when we're thinking about the media and the role of different forms of research in the media and how we need to be better literate in how to sort of try and navigate that media space. And Sizwe also shared, you know, correctly that Zamazamas are a prime example of migrants working in dangerous environments. And my question, you know, back is around what's driving that, right? So like thinking about structural factors as much as direct danger to yourself through injury. Not everyone's going to know what Zamazamas are. Does somebody in the room want to explain, or Sizwe, can we hear you online? And you can just share with us who Zamazamas are for those who might not be familiar.
Okay, thank you so much, Prof. Zamazamas are essentially migrant mine workers that are working in the illegal mining sector in South Africa. So me and my friends were discussing this, and she's an occupational therapist, and she was asking me a question about whether occupation is a choice. You know, so the issue of Zamazamas came through to me to say, do I think that Zamazamas have a choice of going to those dangerous mines and you know, in those holes to try and make a living? And why is it that it's only migrants who are found to be working in these conditions? So I thought that was interesting for me.
Great. Could I have 2 points? One is actually on the narrative part. I think it's very important we have to be crystal clear on what we present and how we say. Again, importance of terminologies, you know, refugees, asylum seekers, labor migrants, irregular migrants, stateless, and so on and so on. They are not all the same. It's a legal system. So we need to be clear what we talk about, which it's one of the ways how can be clear about what is being said in media, but we cannot control all of it. You know, I often have the stupid example of an axe. It can be used to chop down a tree or injure a person. The axe doesn't do anything by itself. Let's say we say that the HIV thing, 50% of migrants are actually among the newly diagnosed HIV. That's a fact. I can say that the prevalence of HIV in this country is increased by 50% by migrants, which is also true. Or say that half of the prevalence is amongst migrants without saying. So it's about how we present and what we, again, understand the difference between data, results in your paper, and how it is being presented. The other thing also discussion on the, because you said the case of Sama, we often have this because I think our brains are less developed, we have this dichotomy, forced and non-forced migration. My thesis is that us all human beings are kind of lazy. If we get everything what we need where we are not going to move. So the ones who are forced to move to work in illegal mines, or the ones who are forced to move to Middle East or to UK to work as a nurse, I'm sure they don't want to, like, say, from India, the part I come from, it's 30 degrees throughout the year. It's always sunny. We get tropical fruits. Why should I go to UK when it is cold and rainy and it's 17 and 15 and then still have to work with all those things, leaving my family behind, my parents and others? No, because I want to have a better life. Is that forced migration? In the literal sense, probably not, but in the philosophical sense, yes, because I was forced to migrate because I couldn't get the income I need to live with the conditions I have. So also see the larger spectrum rather than as a box, as a block line, forced and unforced, because I often say that I think any form of movement is a force. And then the question is how pronounced, how strong the force was. Did it cause injury and health? Then it's definitely really forced. The other one is like have a better life. Thank you, Joe. Sure.
Great, thank you. I think huge thanks to Soorej and to everyone for your engagements. And I'm happy that colleagues online are able to follow. What I've done is I'll also just send a link. There is a guest Wi-Fi. I'm not sure where the password is, but if you're just so that some of you I know prefer to follow through the slides directly, but I'm also adding in there a document where, you know, feel free as you're listening or thinking to add any comments, thoughts, resources, so that we can collectively be sharing and collating. I've shifted the program a little bit, so we're going to take tea now, but I'll ask if we can start again at 20 past. So we'll have a 15-minute break. We'll then move on to Anuja's planned, and we'll just start lunch a little bit later at 12:45. The input I was going to give, I've moved to the day when we're looking at scoping reviews anyway, so it's really not disrupted the program. And I'm so excited that we have Soorej with us and that we also have Anuj today. So fantastic that they're kicking us off this morning. So yes, and colleagues online, we will be starting back in 15 minutes. Thank you. There's tea, coffee, food. I suggest go enjoy the sunshine. It's much warmer outside.